the recording. Good morning. Welcome everybody to our September Win for Supportive Housing Learning Community webinar, where we're going to be talking about trauma-informed care. The title of our webinar today is Establishing Safety and Trust in Supportive Housing Through Trauma-Informed Care Training. My name is Emily Bands, and I am going to be facilitating the webinar today. Before we get into content, I do just have a couple of housekeeping things to go over. So welcome. Today's webinar is hosted by DBHR through the Washington State Healthcare Authority. This is an interactive training, and we encourage you to ask questions and participate throughout the session. The slides, as well as a link to the recording, will be sent by email after the presentation. I think that has changed a little bit. We're now going to be putting this in the chat at the beginning of the presentation and at the end of the presentation, and then the YouTube video will be available DBHR YouTube channel within the next couple of weeks. And we will make sure to update that slide. A quick note about artificial intelligence. Please note that the use of automated note-taking bots or similar tools during Washington FCS events or meetings requires prior approval. Unauthorized use of such tools is prohibited to ensure the privacy and confidentiality of all attendees. Also, any recording that is created through AI is not recognized as an official recording of the session. We do reserve the right to exit trainees, from the training if they're using AI to take notes without prior approval or using AI to record the session. And just note that materials and recordings will no longer be emailed to participants. Materials will be uploaded to the chat during today's session. As I said, I dropped it in the chat. I will also drop it into the chat at the end or kind of closer to the end. And just know that the recording of today's session will be available on the HCA FCL approximately 2 weeks after the session. If you download the PDF that's into the chat and you click on that, you should be able to just click on that link and it should lead you directly to the YouTube page because they are clickable links. All right, let's get started talking about some of our content today. So the purpose of our webinar today is to really focus on trauma-informed care and how you can implement and use trauma-informed care and trauma-informed care principles and practices. So our first learning objective is to just define trauma-informed care and its relevance to supportive housing. Identify some strategies to create physical, emotional, and psychological safety for residents and participants in your programs. And then we're going to recognize trauma-informed practices that strengthen the staff-resident relationship. And that really is going to hone in on and focus on support and how you can continue to support folks. So let's start out just kind of defining what trauma is. And I kind of want to ask all of you, instead of me telling you what trauma is and defining it, I know this is probably not your first presentation that you've sat in that is focused on trauma. I'm sure it will not be your last. So what are your thoughts? How would you all define trauma? And feel free to type it in the chat, what you're thinking about when it comes to trauma and what that means to you. Right, we're getting some good stuff in the chat. So an intense moment in your life, a bad life experience, Anything that affects a person's mental or physical safety. Yes, Leanne, you're definitely on the right track. Overwhelm with what is demanded of you. Kimberly, an event or set of events that can change a person's entire experience. Absolutely. Alexis, you said, I always think of trauma of something that disrupts the way your brain takes in new information. Absolutely. Experience something that is a traumatic event, it really has a significant impact on us, as well as our brain, and kind of how we are, you know, going to perceive life after this event. Um, Sarai, I want to say that's how you say your name, an event, minor or major, that affects the remainder of your life. Yes. And I think it's really important. It could be minor, quote unquote, minor, or it could be major, right? When process something as being traumatic, it really is something that is an individual experience for us, something that might seem minor to us, might seem major to someone else, and something that might seem major might not have an impact on somebody, but something that is minor to a different person could have a significant impact. Diane, experiences that negatively impact your life. Michael, anything that elicits an emotional response due to stress or a stressful situation. Katrina, you said it's relative, which to me could be normal from another person. We are on the same wavelength here, Katrina. Absolutely. Tanja, harm, physical or emotional. Shannon, stressful or very emotional, frightening feelings coming from an event. What happens inside of you as a result of an event. Yes, you guys are all on the right track. Eliza said very stressful, frightening, or distressing event. That could be one event or multiple events. And thank you for adding that in, Eliza, right? Because it doesn't necessarily one thing that has happened. It can be a set of events or a set of circumstances that impacts you. So if we're going to look at like a broad definition, we think of trauma as an event or circumstance that is a distressing threat. It's something that can be experienced as physically or emotionally harmful, or something that is life threatening. Happens is during this event, right? The stress of the event is what overwhelms us and our ability to cope with the event. And there are negative lasting effects on both our psychological and our physical functioning and well being. And when we think of different types of trauma, and again, you all are right on the right track of what this definition is. But when we think of the different types of trauma, there are a few different types of trauma that we can really think about. So there could be an individual trauma, and again, individual trauma is something that's just happened to be one person on an individual level. A mass trauma is something that is happening to multiple people multiple times. Racial trauma, we're going to get into that a little bit more, but racial trauma is an event that or more of a series of events that people experience related to discrimination. Historical trauma, something that we might think of as like a historical trauma. I think the best example that comes to my name is like 9/11. Something that is so large, so wide scale that it's having lasting impacts and impacting history, really. And then complex trauma. And complex trauma is something that spans over many years. It's something that has very lasting effects. And it's something that is very layered and nuanced. So it could be years of abuse or neglect that someone has experienced versus like an individual traumatic effect, like maybe getting into a car accident. Not to say that a car accident couldn't turn into a complex trauma, because I definitely think it could, especially if multiple car accidents occurred. But that would be something that would stand at like an individual level initially. So I wanted to just kind of orient us all to what trauma is and the different trauma types, jump into what we're going to talk about. So let's think about trauma in the individuals that you are working with. Think about any of the individuals that you're working with. or maybe you have one particular person in mind. How have you witnessed trauma impacting the people that you are providing to? How has it impacted maybe their ability to host? How has it impact their ability to maybe work or participate in the community? How has it impacted their quality of life? How have you seen impact some of your service recipients? All right, I'm getting some worth. Sure, I can absolutely repeat the question. So, how have you witnessed trauma impacting the individuals that you're working with and providing services to? So, clients feel defeated, like they don't want to try because historically they have been rejected due to previous justice involvement, credit scores, or lack of rental history. Chandra, you work in substance use disorder treatment. The majority of your clients have experienced trauma and will turn to self-soothe. Yeah, it's like a vicious cycle. Um, Audrey hinders trust with service providers, makes stressing, causes housing to feel like a giant task to maintain, impacts everything from fear riding the bus to choices in relationships to vulnerability. So many ways, absolutely. Fear of change, comfortable living in high stress environments, resistance to positive stresses too. I would also say potentially lack of trust with other tenants and maybe with you and other staff, as well as maybe even people at their program or friends. Yeah, Shannon, on the same wavelength. Do not trust anyone, have ongoing substance use disorder and mental health. Trauma survivors at times freeze. They can't motivate themselves to care for themselves. PTSD, experience dominated their thoughts, and just about every conversation got steered back to that experience. Not being able to live life to the full potential because they've had that experience of that traumatic experience. Say it keeps them from allowing themselves to get certain services. It keeps them in the place we are trying to get them out of due to the lack of self esteem. Creates reactions, not able to trust, feeling unsafe, affects the population we serve in every aspect, self awareness, worn down physically by sleepless nights, intrusive thoughts, dependent on the situation, isolation, self harm, shutting down. You've seen lasting impacts in all aspects of life, most commonly struggle with trust, confidence, and ability to move forward. And I ask you about all this because this, I'm going to go out on a limb here, and you can definitely chat if this is correct. This is going to affect service provision, right? And it sounds like it's affecting service provision in a multitude of ways. It's affecting the ability for people to stay housed in some ways. It's affecting the ability for the folks you're working with to trust you and maybe build that therapeutic relationship with you. It's impacting the individual's ability to believe that they can work toward goals and maybe achieve some of these goals that they're working for. Um, and Kimberly, you said I found that professionals who have lived experience themselves are able to connect with the population we serve, and it fosters trust, one of the most important factors in the therapeutic relationship. Yes. And that makes sense, right? When you have somebody who has experienced a similar trauma or has just kind of experienced a traumatic event in general, you can empathize in a different way. Um, and that can feel a little bit more trustworthy for folks. But it's important to kind of consider all of this in the context. If you've been to any of the other presentations I've done, I'm all about context. Context is important, and I think this establishes a really important context because it's creates difficulty for all of you when you're trying to provide services. So it's important that when you are working with folks, that you are coming from this perspective of trauma informed care, because that's going to support you to help the person kind of overcome and navigate some of these impacts that they're experiencing from traumatic events. So let's talk about trauma informed care and what it is. So, trauma informed care is an approach to providing services that recognizes the impact of trauma on the people that you're working with, recognizes and understands signs and symptoms, responds to the person and their symptoms and their experiences by integrating knowledge into practices and policies within your organization. Um, so, really rooting everything you do in this trauma informed care approach. And it also seeks to avoid re traumatization. So, trauma informed care really is a strengths based, person centered approach, which is, I'm sure, very much in alignment with the work that all of you are already doing. And it really focuses on shifting the mindset from what is wrong with the person to what happened to the person. And again, it's something that is encouraged to be incorporated at the bottom to top level of an organization. So it's not just incorporating certain practices into your work or into your team. It's really thinking about a cultural shift within your agency and within your organization. And I think I'm happy you guys are excited about that. Has anybody heard about trauma informed care before? Is this a term and kind of terminology that you all have heard before? All right, cool. So I'm not going to get into um, too much more about like the kind of higher overview of what trauma informed care is, which is good. It sounds like a lot of you are familiar with it. What I am going to do is just very quickly go over the 6 principles of trauma informed care, because these 6 principles really guide the types of services that you all are probably already providing if you're using a trauma informed care approach in your work, or will look to provide, right? So the first principle is this is really focusing on ensuring physical and emotional safety for the individuals that you're working with. Trustworthiness and transparency. Excuse me, that's ensuring that really clear communication between you and the person you're working with, that there is kind of no questions about what you're asking or what you're needing a person. Through that transparency and communication, you're building trust. There's also a level of peer support, which is very much in alignment with what I can't remember who said it earlier, but someone had noted that it can often be helpful to have somebody who has maybe experienced a traumatic event to provide support, right? That peer support. Um, it helps to kind of harness that lived experience, and that can help promote healing, right? Because when you are experiencing something, when you're seeing another human being who's been through something similar and seeing what they have worked through and what they've gone through and what they've accomplished, that can be very empowering for folks. There's also this idea of collaboration and mutuality. So there's not really going to be a lot of power differentials, right? You're really looking at you as a service provider and the service recipient as being on the same level, and really being mindful that we're not enforcing kind of power differentials. Um, and yes, absolutely, Kimberly, that's a great point. When we practice trauma informed care in our private lives, it becomes natural in our professional lives and experiences. And I think this is a good way to think about it, right? Especially coming from this idea of like a cultural shift, right? When it's something you're really embodying, it's going to be a lot easier for you to practice this at work when you're already practicing it in your personal life. So that's a great point. Thank you. Um, And then the final two principles are empowerment, voice, and choice. And that really is focusing on autonomy, and really giving the person the opportunity and the support to make their own choices, and to go down the path that they're interested in going down. And again, really focusing on that person's strengths, really focusing on supporting that person to build them up. And then there are cultural, historical, and gender issues. And cultural, historical, and gender issues really focuses on um, ensuring that the your organization is being mindful of the person's culture, the person's individual history, and any gender issues that the individual might have, and really looking at the interconnectedness of those things and how they're impacting the person, and whether or not this is potentially related to their trauma, whether or not it's not related to this trauma. Again, really looking at this person from a holistic experience, right? Because when we think about trauma, for certain individuals, their trauma might come from these three areas. Their trauma might come from their culture. Their trauma might come from their individual history. It might come from their experiences related to their gender. Okay. And yeah, a lot about trauma informed care is meeting the person where they're at. The other thing I want to highlight about these principles is they're very much related to psychiatric rehabilitation. And I wouldn't be from the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers University if I didn't speak about that overlap there, right? Because I think trauma informed care and psych rehab really have some overlap in the mindset. So if you are already providing psychiatric rehabilitation services at your organization and your agency, and maybe you're not performing trauma informed care, or you don't know if you're necessarily providing trauma informed care services, you're probably halfway there if you are providing psych rehab services. So don't fret. You're on the right track because there is a really good connection there. Now, trauma informed care is something that is very important, especially when it comes to supportive housing settings. And I'm going to highlight two important reasons. The first reason is that historically, behavioral health settings have a low response or no response to service recipient traumatic experiences. And this is from the research. And in general, this is very disheartening. The other thing I want to highlight is some of this information is from a couple of years ago, but there are a lot of organizations still, I think, across the country and maybe within your state that are not reacting or responding to traumatic experiences from their service recipients. And that's concerning, right? Because again, this is a huge part of a person. This is a huge part of how they're going to react and respond to the services that you're providing. So it's really important to provide trauma informed care because we have to acknowledge and we have to support the person if they have had a traumatic experience. The other thing to consider and think about is trauma prevalence is really high among the people that we're providing services to due to high exposure, right? So a lot of you spoke about having individuals who have substance disorders. Um, when we're thinking about individuals with substance use disorders, when we're thinking about individuals who've been unhoused in the past, when we're thinking about individuals experience abuse or neglect as children. I remember when I was working in supportive housing, I had a lot of individuals that would fall into any of those categories, and every single one of them had some type of traumatic experience. And I would wager that that's the same for a lot of individuals that we're working with have experienced trauma. And yes, we're going to talk about ACEs in a second. We'll get there. A lot of the folks we're working with have experienced a traumatic event, and we can't ignore it, right? Because there are these lasting impacts that are going to influence our ability to provide services to folks. So we have to be able to have a way to recognize, to acknowledge, and to support folks who have had traumatic experiences. So, Tamara, that's a great question. You said curious if there's any how employers recognize and support direct service providers who are susceptible to vicarious secondary trauma and compassion fatigue. So, Earl, I know my colleague Earl is here from Rutgers. I'm going to actually ask him to speak to this because Earl has presented on this topic before. If you would be so kind, Earl.
Sure. Hi, good day. So let me make sure I get the question correctly. Curious if there's any data on how employers recognize and support direct service providers who are susceptible to vicarious secondary trauma and compassion. Um, from what I know, I don't know so much about the collection of data across agencies, but there's certainly some data on clinicians or people who provide treatment and that kind of service at the clinical level. Um, but ultimately, I think the reality is that we have to look at it from the perspective of everyone who work with people who are oftentimes dealing with diverse trauma are inclined to have some level of vicarious trauma and secondary trauma. So the idea is to actually address it from a default of assuming that everyone can and is likely experiencing it, and therefore to have that kind of support, that kind of ongoing reflective supervision, and the commitment and motivation to work on addressing your own trauma, whether secondary or primary.
Thank you, Earl.
You're welcome.
And I think that mindset makes a lot of sense, right? More often than not, I'm sure a lot of you out there have had an experience with secondary trauma or vicarious trauma and compassion fatigue. I know that I have. I'm sure Earl has. So it probably is better to assume that this is something that your staff, from a supervisor perspective, this is something your staff are going to experience and address it as such. Um, so great question. I want to get into a little bit of practice here because one of the principles, and I'll just go back to the slide, is safety. And safety is something that is really, really important for individuals who have had experiences with trauma. And I think this is an area, in addition to kind of trustworthiness and transparency, but this is an area that a lot of you frontline staff are really going to um, be faced with, right? Just in the day to day work that you all are doing with folks. So I have two case examples. And I wanted to take a little bit of time to talk through these examples and really think about how you could potentially support a person in this type of situation. And I think these examples are I know as I was coming up with these examples, I was really pulling from some of the things I experienced working in supportive housing. So I'm going to go out on a limb and say that this might sound a little bit familiar to you all. And let's brainstorm and kind of work together to figure out how we might work with these two folks. So the first person we're going to work with is Marisol. And she is a 47-year-old Afro-Latina woman living independently in a one-bedroom apartment. She's bilingual, speaks Spanish and English, and lives with a mobility impairment and experiences symptoms of bipolar disorder and PTSD related to past intimate partner violence and experiences being unhoused. Since moving into her apartment 6 months ago, Marisol has expressed concerns about her physical safety. The front door to her building is often left propped open, and unfamiliar individuals frequently loiter in the hallways, sometimes engaging in harassment towards her and others. Inside her apartment, there's clutter and limited mobility, making it difficult to navigate safely for her, especially in the event of an emergency. She has no visible emergency contact information and is unsure of how to respond to a situation like fires or medical incidents. Marisol also feels hesitant to report building issues due to past negative experiences and fears of being targeted or dismissed. So, my question for all of you is, if you were working with Marisol, how might you support her in creating physical safety in her environment? What are things that Marisol could specifically do to create physical safety within her environment? And also, what are things that you could do with her? So a little bit of what Marisol might be doing as an individual, maybe independently, maybe with your support, and then things that you can kind of do with her or individually to support her. Let's brainstorm. Let's think about it. Absolutely. She could add additional locks to her door with the large just to kind of help her to feel a little bit more safe. Kimberly, you could support her and install a ring camera as no one who's around your home, especially following intimate partner abuse. Absolutely. Um, Either a camera or if it's possible, like a doorbell. I think that's a great something great to add. Audrey, work on a safety exit plan for her unit and how she would vacate in case of emergency. You could coach her through approaching the landlord for a discussion about building safety and her concerns. Yeah, I like this. So, first, right, having this safety exit plan for her so she knows which route to go to get out of her unit. And maybe even thinking about if there's a lot of clutter in her apartment, you know, there's definitely some steps you could take to help to reduce that clutter, but maybe ensuring there's a clear path and then creating the safety plan so she knows when she leaves her apartment which direction she goes, left to the staircase, right to the staircase, whatever that is. And then also doing some coaching and some support with her about how to speak to her landlord about some of these issues and maybe even advocating, right? And advocating for her on her behalf. Yep, in align with a safety plan. Absolutely. And the safety plan might also include, um, some type of emergency contact sheet with like important numbers in addition to like 911. Your phone number could be on there, maybe a friend or like a family member, someone she can call. That could also be something to add into the safety plan. Um, Absolutely. Alicia or Alicia? I don't know. We'll see. But you said you would attempt to validate her feelings first and then ask if she'd like help speaking with her landlord. Absolutely. Speak with building management about safety concerns, making sure they're aware of the situation. Diane, absolutely help her declutter her apartment to create a safer space, excuse me, to move around. A building action plan for emergency strategies, incorporating phone numbers for emergency services and her emergency contacts. Also, work on safe should an emergency arise, right? Like, what does she need? Would it be helpful to her, like a little bit of like a go bag? And maybe creating something that she could take if there is an emergency in the building, who to talk to, things like that. It also support her in installing longer screws in her front door frame, as standard screws are 1.5. I would also support her in establishing a safe exit plan and help her practice and act it out. Kimberly, I have seen that Instagram video as well about the screws 1.5 inch screws are. So thank you for bringing that up. John, walk her through responses to emergency, like a personal fire drill. So I don't know if any of you have worked in like but I know in A+ group homes, they have fire drills. I think one of the agencies I worked at, I think it early, they did a fire drill. And they just kind of did it themselves, right? They just said, okay, we're having a fire drill. And then, they set a timer. They made a specific place to go if there was a fire. So I think that's a great idea, John, to kind of incorporate that and help her, a safe place to go to if an emergency does occur, where she can meet up, et cetera, et cetera. Ludine, safety planning, and then practicing what that looks like. Earl, on point, right? Asking her about what safety looks like to her, when she felt safest, what can we get closer to that desired state, help her develop a safety plan that is nuanced to her experiences and desire. Absolutely. And this is where I love that collaboration, right? And that autonomy, and incorporating that trust that, like, hey, we're here for you, Marisol, what's going to work best for you? Establishing her knowledge of voice and choice. Absolutely. I'd ask what has made her feel safe in the past and how can we use that to assist her now. If she would like, complete a safety plan to include inside and outside of her building, assist her with talking with her landlord, building management regarding keeping the overall building safe, talk about connecting with mental health support. Absolutely. Talk to her about creating their residents. I love that, Tandra, right? Helping to kind of get her involved. Maybe there's some of her neighbors who are also concerned, right? Whether that be other people on the floor, or maybe other people on different floors that she can connect with. Practicing an exit plan creates a muscle memory for quick, safe exit. Continue to connect her with needed resources in the community. Practice mock situations with her landlord, physician, and absolutely. So just some other things to kind of think about, and just kind of getting a little more specific. So it might be helpful with her permission, as someone else said, to do like a walkthrough, right? And maybe help her to either identify any like tripping hazards or blocked exits or safety risks. And also, for you, pointing some of these things out to give her like a clear idea. Maybe she's not recognizing, maybe you're recognizing something, but she's like, nope, I know what to do, and how to move that. I'm fine with that being there, et cetera, et cetera. Talked about either accompanying her to speak with her landlord, or maybe just doing some advocacy on her behalf. Something else that could potentially happen, or that might be helpful for her, just kind of acknowledging some of her mobility stuff. I wasn't specific in the scenario about what mobility issues she's experiencing, but she might feel safe with like a medical alert button, or some like one of those like necklaces or something that she can wear. And absolutely, Alexis, right? All of this is with her consent, and all of this is a collaborative conversation. Really keep those 6 principles of trauma-informed care. One of those is autonomy. So we really want to make sure that these are things she's on board with. But just kind of offering some additional suggestions. Maybe it is a medical alert button. Maybe she's also feeling unsafe in the shower. So maybe it's installing some bars in her bathroom, as well as with the landlord approval. Maybe it's getting like a shower chair. Just kind of seeing what type of mobility devices would be helpful in the bathroom. And then also just some things to do on your end, right? So again, really asking for permission every step of the way. Um, Making sure that you are asking before coming into her apartment. Making sure that you are asking, even to, if you can make a suggestion, right? Something that I kind of incorporate as I'm working with any client is, do you mind if I make a suggestion, or can I make a suggestion? And that lets you know if the person's open to it. And they might change their mind to rescind that consent after you make that suggestion, and that's okay also. Getting in into that habit to ensure that she's okay with that. Again, making sure that the space is clear and working with her to do that. Something else that might be helpful is having like a safety buddy. So maybe there is a neighbor or someone else in the building, or maybe someone who that she can contact if she is feeling like there or she's in a crisis. She might also have a friend who she knows she can call if she's coming into the building and she's feeling uncomfortable because there's a lot of people outside, and she can just stay on the phone with that and get safely into her apartment. Or maybe it's just a text message, right? Like, hey, there's a lot of people outside. I'll text you when I get into my apartment and let them know, like, hey. And if she doesn't hear back from her, then she knows that something's wrong. Um, and then also building maybe more additional community connections. So I know one of you mentioned doing like a almost like a neighborhood watch or community safety kind of board or something within their apartment. That's a great idea. But what other maybe types of community resources are out there for Marisol? Maybe there's like a women's group. Maybe there's a group for women who have, or people who have experienced intimate partner violence. Um, Anything like that could help her to kind of feel more connected to the community and help her to feel more supported. Um, and yeah, absolutely. And Tanja, you tell your clients that I will offer suggestions at times, but that is all they are, suggestions. Experts in what they need and get to determine what we work on. Absolutely. That's 100% the way to go. So I hope that this was helpful in kind of figuring out some concrete things for physical safety and supporting physical safety for some of the folks that you're working with. Hopefully, some of the suggestions that were made are things that you can kind of put in your toolbox. Let's think a little bit more about emotional safety and psychological safety for somebody living in the community. So let's think about Joe. So Joe is a 39-year-old Indigenous man diagnosed with schizophrenia, currently living independently in a one-bedroom apartment through a supportive housing program. Experienced severe physical abuse and emotional neglect throughout his childhood and has had multiple hospitalizations in adulthood triggered by isolation. Although he is currently stable on medication, he often struggles with trust, hypervigilance, and feelings um, of worthlessness. He keeps to himself and is easily overwhelmed by loud voices, unexpected visits, or abrupt changes in routine, which can cause him to become withdrawn or experience paranoia. Joe has expressed fears that staff might turn on him or that neighbors him, but he's reluctant to open up because of past experiences of or judged. Building emotional safety for Joe is key to his housing stability. So, what might we do to support Joe in building some emotional and psychological safety? And what are things that maybe Joe might be able to do that we can support Joe in doing or encourage Joe to do? So, Katrina, are you saying that for Joe to share, or for like the staff or staff person to share? Staff. Yeah, absolutely. Um, Ton, you said join a support group that aligns with his culture and identity. Kimberly, you said I would move slow and with intention and connecting with him, own facial expressions and body language and movements while interacting. This is somebody who I think when working with them, we would have really intentional and mindful of our own presence when working with him, especially the things you mentioned, like your tone of voice, your facial expressions, your body language, movements. For me, right now, I don't know if you guys have noticed, I'm talking a lot with my hands. That is not something that if I was with Joe, I'd be very mindful of that because I want to make sure that he is comfortable and doesn't think that I'm feeling angry or aggressive. Any other suggestions or things to consider? That's great, Katrina, right? Letting him know that he's not obligated to talk about anything specific. You're there to help. You're there to support his choices. Absolutely. Absolutely, Carrie, right? Work to reduce spaces in the building and unexpected visits from staff or service providers. Um, so something that maybe might be helpful is like maybe something like white noise machine, or maybe like playing music is some help to like drown out some of the noise if there is a lot of noise. Maybe it's about ensuring that the unit is far away from like the stairs or the door. Maybe he's hallway where maybe there's not as much like foot traffic. And then, yeah, making sure there's not any unexpected visits from staff or providers. And also being mindful if somebody new has to come and meet with him and making sure that he's aware. And also that maybe there's an opportunity for for everybody to meet, right? So if you're going out and meeting with that person, the staff that's going to be potentially meeting with him every so often, like if you're out sick, also come so that Joe has met them, knows who they are, has an idea of what they look like, and isn't surprised when they come and meet with him. Ton help him recover his hobbies, things that bring him joy on a slow pace. Yeah, like what is Joe like, right? We don't. There's a lot we don't know about Joe because I kind of made him up, but who is he? What is he like? What are his passions, right? Maybe it is music, maybe it's something creative like art. Maybe he is a musician, maybe he's a writer. Maybe there are other creative outlets that you could help him to kind of reintroduce him to. Kimberly, once we built a level of trust, I would support him in establishing and implementing a routine that he feels truly works for him, right? That structure of a routine is something that could be very helpful for him. I think that's a great idea. Tanja, make sure that you are consistent in appointment times, no last minute rescheduling or canceling. Absolutely, right? That consistency is something that he's probably going to be very mindful of, right? And you want to show him that he can trust you, and to show him that he can trust you, you got to show up for him, right? So that's something to be mindful of. And then also discussing referrals to NAMI or other support groups. I love that. Work with him to make a schedule of check-ins. He struggles, it seems, with changes in routine. So start to build a new routine and be a reliable constant for him to build that trust and help him learn. We can be counted on and aren't going anywhere. Absolutely, Jennifer, you read my mind. Um, and absolutely, you have to build that rapport. Um, Make sure he feels safe and heard, respectfully and intentionally learn what his hobbies are and what makes him happy. Be flexible and patient. Katrina said, in your early days, I upset one of my participants by asking him his social security number while I was helping him fill out paperwork. He became visibly upset, and I had to scrap our plans for the day because he was agitated by that. Yeah, being right, and I think that's a really honest mistake to make, Katrina. And it seems like it's something that you learn from, but I can understand, right? You're helping him fill out paperwork, so it's like, what is your social security number? It's time to put that down on the paper and recognizing like, oh, this is something that this consumer was not happy that I asked about, right? So just being patient, being mindful, and again, that autonomy. Can I help you with this? Is it okay if I ask this question? It looks like you need this information. Can I ask, do you know this information? and just being mindful about how we're wording things. But mistakes do happen. Being consistent. I love this, Kimberly. Learn what happiness looks like to him. Don't make promises you can't keep. Um, Ton, you said TBI training helped me understand how to move slower for comprehension clients. Yeah, so just being mindful of your pace. I would say over here in New Jersey, we're very, very fast paced. And we're just kind of zipping through things. And that was actually something that I struggled with initially when I was working in supportive housing, was really slowing myself down. Not just um, how I was working, but even sometimes my energy, right? Sometimes we really have to be mindful of our energy and kind of the energy we're putting out there and really slowing that down, in addition to like our pace in terms of our voice, our pace in terms of our actions, and really letting the person that you're working with set that tone for what the pace looks like. But you guys have hit on a lot of the things that I wanted to suggest. So again, that consistency with having a lot of really predictable visits, letting him know in advance when you're coming, and making sure that if he's expecting you, you are there and you are on time. Um, Again, making sure that you're being mindful of your language, of your body language, of your tone of voice, and being mindful of asking for permission. Would it be okay if I gave a suggestion? Would it be okay if we talked a little bit about X, Y, and Z? If not, that's totally okay about it. Really making sure we're validating how our clients are feeling, especially for Joe. Making sure we're giving him options, right? And helping him to really have that choice. Did you work out filling this application first, or did you want to take a walk to the corner first and get something to drink? Did you want to meet in your apartment, or it's really nice outside and we can go walk? Um, and then some of the things I'm going to kind of just mention, we're going to talk a little bit more once we get to coping skills, which I'm going to talk about at the end. But something that could also potentially be helpful for Joe is some like grounding techniques and grounding tools. Again, maybe doing a personal safety plan like we talked about for Marisol, just so that if he is feeling a little bit concerned about what to do in a crisis, having that plan is something that might be helpful. A lot of you mentioned, what's his support network? And if he doesn't have a support network, helping him to build a support network in the community or in his building. Um, Making sure that we're being mindful of, respectful of Joe's boundaries, and also maybe teaching him about boundaries and helping him to either learn some of those skills or strengthen some of those skills, right? Maybe teaching him how to say no. Maybe teaching him how to, decline a request. And doing so in a way where he can communicate assertively and effectively is also maybe something to consider. And then again, figuring out what some of his hobbies are, maybe encouraging some journaling, that could potentially be something. And yes, absolutely, Ton, mindfulness is something that can be really helpful, especially if someone is feeling very stressed or anxious or elevated, as you said. So again, I hope this kind of gave you a good sense of what implementing the principle of ensuring and creating physical, emotional, and psychological safety can look like. And it's you guys are on point already, and I hope that some of the things we talked about are things that you can again put in your toolbox and use in the future when you're working with folks. When we're thinking about trauma informed care, we do want to think about it as this shift in your organization. But there's so much that you can do working with the person one on one to really ensure that you're providing that trauma informed care individually. So, we're going to keep talking about how to implement trauma informed care in supportive housing settings. And the first thing that I want to bring up, and I know someone had mentioned this, is talk about how we can recognize and assess for adverse childhood experiences. So I'm not going to spend a lot of time talking about adverse childhood experiences. I believe this is something that Crystal talked about in a webinar that she did in the past. But just to kind of give a brief overview, adverse childhood experiences are potentially traumatic events that can occur and do occur in childhood that end up having very lasting effects on a person. From the CDC, 64% of adults in the US have reported experiencing at least one type of adverse childhood experience. When we're thinking about what adverse childhood experiences are, they're experiencing things like violence, abuse, or neglect, witnessing violence in the home or in the community, having a family member attempt or die by suicide, witnessing somebody in your home experience substance use problems, mental health conditions, having instability due to a parental separation, as well as instability due to household members being in jail or being in prison. Um, ACEs have a lot of impact on folks, right? So they increase the risk of injury, sexually transmitted infections, and involvement in sex trafficking. There are also maternal and child health problems, including teen pregnancy, pregnancy complications, and fetal death. And there's also a range of chronic diseases that individuals who have had adverse childhood experiences have, like cancer, diabetes, heart disease, and then unfortunately, individuals do uh, what's what's the phrase? Um, they die. Individuals who die by suicide. Sorry, I'm trying to be very mindful of my language. Um, what the big focus and the shifts when it comes to ACEs has been on preventing ACEs, because we know that preventing ACEs can positively impact the life and health of adults, because individuals who have experienced ACEs experience a lot of these negative impacts that I just talked about in adulthood. Unfortunately, though, if you are only working with adults and you are not working with children, the time to kind of stop individuals from experiencing an adverse childhood experience has passed. So essentially, what we are now doing is we're working with individuals who have experienced an adverse childhood experience. So something that is really important and really I don't want to say simple, but something easy that we can kind of do is screen for adverse childhood experiences for individuals coming into your programs. How many of you out there, how many of your organizations screen for adverse childhood experiences? And I'm going to stop for a second. I'm going to stop sharing because I want to bring up this assessment so we can see it a little bit better. So, Ton, you said that your organization does screen for adverse childhood experiences. Do any other organizations screen for adverse childhood experiences? And if not, that's okay. Um, this is something that I know that some agencies don't do that might be helpful. So that's why I've included this resource for you. So this is the Adverse Childhood Experience Questionnaire for Adults. And it is something that was developed by the California Surgeon General's Clinical Advisory Committee. It is a 10-question questionnaire that individuals can take. And the person's ACE score is the total number of checked responses. So basically, the individual just notes whether or not this is something that they experienced. And they also note whether or not they feel like these experiences have affected their health. Um, So Jessica, you said the prevalence of ACEs are high among residents and staff. We have asked if we really need to do this to provide excellent care um, from a trauma-informed approach. Um, so I would say if you are looking to come from a trauma-informed perspective and approach, screening for these types of things is something that's really can be really helpful, right? Because we can assume that a lot of people have experienced these things. But I think in what is a little bit different about thinking about supporting staff versus supporting individuals is I think there is an expectation that we're providing individualized services, right? And the adverse childhood experiences that people are going to experience are probably going to be different, and the way that those experiences are impacting them are also going to be different. So I think this question is something that is really important once you have talked about these things, right? Do you believe that these experiences have affected your health? And this is an important question because either the person's going to say yes, and then you can go from there and kind of support the person to navigate how these things are impacting them moving forward. Or the person's going to say not much, but maybe you're seeing other things. And those are things that you have to be mindful of that could potentially be barriers for care. So I'm of the thought process that screening is helpful. I know that the intake process, it can be lengthy, but this is definitely something to do at some point, even if it's not on day one after, you've done a bunch of assessments. It's something that can be helpful to include in your intake process, maybe over the first 30 days of treatment or of services. Um, so that's a great point, Diane. In terms of adverse childhood experiences, I don't know if, and I have I think I linked the website from the CDC on the left side. I'm not sure if adverse childhood experiences generally include and have it brought into other adults who may have harmed the child outside of the home. A lot of what adverse childhood experiences looks at is what is happening inside the home. So that's I think is the rationale why that's not on there. But I'm not 100% sure. Um, so let's see. There's a couple of stuff in the chat. So Tandra, you said you do on individual cases with some clients and behavioral health care. Kimberly said your program doesn't screen for ACE. However, your coordinated entry program for housing referrals does. Jessica, you bring up a really good point. How to screen is key. And this is not something where we're just handing out the form to the person. So this is something that can be completed individually, but it is, providing screening forms and assessments, like I'm going to go over the next couple of slides. We do have to be very mindful that we're doing so in a very gentle, intentional way, that we're not just simply handing them the piece of paper, to Jessica's point, but that we're sitting down, we're having a conversation, we're being mindful of the environment. This type of screening, in addition to the other two that I'm going to go over, are screening questionnaires that are probably going to bring things up for people or could bring things up for people, right? So this isn't something that is, 10 questions that should take 10 minutes, right? This is something you want to do leave some time for. You might have to include some grounding techniques in here if the person starts to maybe feel a little bit anxious. They might need breaks. They might start and you might have to hop back on a different time and finish it out at a different time frame because it's very overwhelming for the person. Um, being just very mindful of how we're doing that. So thank you, Jessica. That's a really great point. All right, so this is the Adverse Childhood Experience Questionnaire for adults. This is free online. There are other types of ACEs questionnaires on there. And yes, so what I will do is I will go back to the PowerPoint for a second. And So what you will see, Lavanda and everybody else, is the PDF. All you have to do is click on this, and this will open up to the link for the questionnaire. Okay, so you should have access to that. So the next thing we want to consider is we want to recognize and assess for racial trauma. And this is something that is important to assess for, because again, this is something that can, I think, contribute to more complex trauma for folks, because racial trauma is not just a one time event for a lot of individuals, it's a long term um, sequence of events that people experience. Okay. So when we're thinking about what racial trauma is, it refers to the emotional impact of stress related to racism, racial discrimination, and race related stressors, such as being affected by stereotypes, hurtful comments, or barriers to advancement. It can refer to a specific incident of racial discrimination or the ongoing harmful emotional impact of racial discrimination that builds up over time. Tanja, to your point, it can also be generational trauma. Absolutely. So people can experience racial trauma from something that happens directly to them or from seeing others mistreated because of their race. Okay. It's also important to consider that the coverage of events caused by racial discrimination in the media can also be upsetting, and repeated viewing or frequent media accounts can amplify those feelings. Okay. So when we're thinking about the impact of emotional trauma, of racial trauma, right, it's generational, right? And it's contributing to stress, it's contributing to anxiety, it's contributing to depression, it's contributing to PTSD. Okay. So this is something that is very much important to screen for. If your organization is not screening for this, I definitely recommend that this is something you start screening for if you can. And what I'm going to do is I'm going to switch over to this. So this is the trauma symptoms of discrimination scale. It is two parts. Um, so it has the directions. It has um, a little blurb at the top that kind of explains. Um, and these are the questions. So there are 21 questions for people to identify. And then what you're going to do, um, you're going to then identify the type of discrimination that the person has experienced, and then kind of add it up into a percentage, and it's going to add up to 100%. That's what they're looking for here. Okay. This is from the Ross Center, I believe. And again, there are other types of racial discrimination, or I'm sorry, racial trauma assessment questionnaires that are out there. I thought this was a pretty comprehensive one, which is why I included it. But also use the assessment that makes the most sense for your agency and organization. These are just kind of suggestions. But something that we should be screening for, something that we should be assessing in the folks that we're working with, because again, these things are going to contribute to the person that we're working with and their experiences. Okay. And then the last questionnaire I wanted to go over is nope, not this one. What time is it? Let's skip this. Um, I'm going to skip those questions. And this one is specifically for trauma. So what I was going to ask is, does your organization screen for trauma during the assessment process, and what tools are you using? If you're using a specific tool and you want to drop it in the chat and share it with your colleagues here in the meeting, I definitely recommend doing so. But this is what I found. This is from the National Center for PTSD, and I'm going to switch back over to my PDF. Because this is actually like a full-on booklet. So this is the brief trauma questionnaire from the National Center for PTSD. It is a little old. It's from 1999, but it's still used. And it's a brief self-report questionnaire that is derived from the brief trauma interview. It is 10 questions. This is technically the first page of the assessment. This is the second page of the questionnaire. So essentially, folks are circling yes or no to has it ever happened to you? If it happened to you, did you think your life was in danger? And if the event happened, were you seriously injured? So again, 10 questions, something that is just specifically for screening, and something to be mindful for when you are screening for folks. Really quick, is this something that your organizations do screen for? Okay, I'm getting some yeses, I'm getting some nos. Yeah, it's something you definitely can change, Katrina. The other piece of this is, there's a lot of questionnaires out there that you can implement. Depending on who the person is doing the intake, depending on who is what their qualifications are. Some assessments do have to be facilitated by someone with, for example, like a license or a master's degree. Some assessments don't. So it is important to kind of keep those types of things in mind when you're coming up with a plan. But screening for trauma in this way, using a specific tool, or even just using questions to kind of talk about, is something that can be helpful. And it sounds like there's like some differences here, or some of those things talked about in the chat, right? So Tanja, you said that we don't have a specific tool, but many of these questions are embedded in our assessment. Kimberly, you said not necessarily. However, we find a way organically to inquire into our client's traumatic background. So yeah, it just kind of depends on, your organization's process, and how to expand on that process to make sure that you are, screening for these things and supporting folks. So I'm gonna go back to the PowerPoint because we have about 15 minutes left, and I have a couple more things I want to get through before we finish. So in terms of just how to offer support, this is just a nice little do's and don'ts of things to consider. I'm not going to spend a lot of time on this because I think a lot of it is pretty self-explanatory. But again, make sure that we're acknowledging and validating, making sure we're asking about their current safety and support, making sure we're giving options and really supporting people in that choice, making sure that they're having a say in terms of permission of what they're sharing versus not what they're sharing, and telling them like, hey, that's okay, you don't have to share everything with me. We don't want to ask for specific details. We're not trying to fix the issue or the problem. It's not always appropriate to share personal stories of trauma in an attempt to connect with the person. In a very specific role of a peer support person, and with the person that you're working with, understanding that, like, hey, I'm a peer because I've experienced something. That's why I'm working with you on this. That could 100% be appropriate. But if the person is sharing about their experience, it probably isn't helpful for your response to be like, yes, that happened to me as well. Right. So just being mindful about how appropriate we're being, if we are going to share a personal story, making sure we're being mindful of the time and place. Um, we want to make sure that we're not assuming to know the thoughts and feelings of the person. And we don't want to ask about the about what happened every time we're meeting with the person. Okay. We also want to recognize negative coping. And this is something to really be mindful of and to just kind of be aware of. And thinking about it in the context of negative coping. Because I think at face value, if you look at avoidance and anger, you might not think of those two things as being negative coping related to the traumatic experience that they had, but it can be. Sometimes you might see avoidance or you might see anger and just think that that person is quote unquote aggressive, or just think that that person is, they're just avoiding leaving their home. They're just avoiding, coming to this group because they just don't feel like it. But the reality of the situation for a lot of the folks that we're working with is this is negative coping that they've established as essentially a coping technique. Um, to support their traumatic experience and to support their coping of their traumatic experience. So just being mindful of avoidance by denying thoughts and feelings and fleeing, as well as anger expressed inward as self-harm or aggression. Okay. Now, what we can do when we have recognized negative coping is we can encourage positive coping. And I have 3 recommendations here that I will definitely be able to get through in the next 5 minutes. So, when the person is experiencing stress, we want to use mindfulness and grounding. Um, After the person is grounded and they're kind of calm, that's when we can look to challenging feelings and thoughts. We don't really want to do that when the person is feeling stressed. We want to help the person get to a place where they're feeling grounded before we start challenging some of what they're thinking and feeling. And then when they're unstressed, then we can move to problem solving. And Tanja, again, great point. The anger is especially prevalent in early sobriety. They're no longer numbing the pain, and that's when they're starting to really feel everything, right? So that is a really good place to really try to implement and encourage this positive coping that I'm going to talk about. So the first thing is grounding techniques. And the link to the article I got this from the Cleveland Clinic is in the references. But you can do things like take breaths, we can listen to music, we can repeat positive statements, we can do some stretch and move our body. We can also play mind games. They give 2 specific suggestions there, but something I talk a lot about with the individuals I work with are different mind games we can play with ourselves when we're really feeling anxious or overwhelmed. So things that I talk about with clients is counting backwards in odd numbers from like 400, um, thinking about all the movies you can name that start with the letter A, thinking about all the songs you can name by a specific artist, thinking about um, times tables, anything that you can kind of think of to kind of get your brain away from that kind of flight, fight, freeze, fawn kind of overwhelm you're experiencing and get into a different place where you can kind of feel more calm and relaxed. Once you have gotten to the place where you're feeling grounded, then we can start changing thoughts. And this technique is called the view from the balcony. And essentially what you're doing in this technique, and this is a CBT technique, it's from this book from Tompkins and Beck. It's a workbook. This is a technique that I think I explained in a webinar I did a little while ago for Washington on CBT strategies, but I really like this CBT strategy because we're supporting the person to kind of take a zoomed out view of the situation. Okay. So what we're going to do is we're going to ask the consumer to describe the situation. We're going to ask them what their negative view of the situation would look like and how strong their belief is. Then we're going to offer and we're going to collaborate to kind of come up with different viewpoints or perspectives of the situation, right? So what else could actually be going on? And this is where the view comes into play, right? Because when we're on the stage, in the performance, we can only see what's in front of us. Or maybe we can only see the other people on stage with us. Maybe we can only see the first row of people watching this performance. We can't see everybody else in the house viewing the performance. So when we're on the balcony, we have a more clear view of what's actually happening, not only on stage, but also what's happening in the audience. Right? So this is when we're discussing these different viewpoints and perspectives. And then once we've gone over these viewpoints and perspectives, that's when we're going to ask the person to rate how true or likely viewpoints or perspectives might be. Once we've asked them how true or likely they might be, we're going to ask them again to re-rate how strong their negative view of the situation is and compare those ratings. So our hope is that by the time we've gone through all these different perspectives, the person is now seeing that maybe what they initially thought about the situation is not necessarily what might be happening. So now their rating of that belief is now decreasing. Okay. And then the last thing we can do is problem solve. And to problem solve, we can use a technique called scale, which is specify, consider all possible solutions, assess the best solution, lay out a plan, and execute and evaluate. So essentially, when we're specifying what the problem is, and we want to frame it as a question. So instead of saying something like, I pay my rent late every month, we want to say, how can I save enough money to pay my rent on time? Okay. So instead of I'm doing this thing, it's how can I do this other thing to get the outcome that I desire? Then we're going to consider all possible solutions by brainstorming and collaborating to list solutions regardless of whether they may or may not work out. So when we're thinking about paying rent, the person might say, well, maybe I'll win the lottery. And you might think to yourself, this person is not going to win the lottery, but that's okay. We're still going to put the lottery on there because technically that is a solution. Because then we're going to assess. Then we're going to review all of the solutions that we put on the list, and we're going to look at the pros and cons of each solution and order the list of solutions, prioritizing the best 2 to 3 solutions for the problem. So maybe they put the lottery on there, but maybe they also know that the lottery probably isn't going to work out. So what we're going to do is we're going to put the lottery at like number 10, but we have 2 to 3 solutions that are really going to work out for us. Once we've come up with those 2 to 3 solutions, we're going to plan because we're going to look at the steps needed to solve the problem, what knowledge, skills, or resources the person needs to follow the plan, and really think about if help is needed and who's going to perform what step. So maybe they have a friend who's going to, make sure they get to work on time so that they can get paid for the day, and making sure they're looping in that friend for that ride. And then we're going to execute. We're going to actually execute the plan, and then we're going to come back and we're going to think about the outcome. Did the plan work? Were the steps that we thought we were going to take, were they accurate? Were there additional steps that were needed that maybe we didn't think about? So now moving forward, we're going to create a new plan and we're going to add those steps. But we're going to kind of go through this process to ensure that if another solution needs to be tried, we know that this didn't work, we can kind of tweak it, and now we can try a different solution. Okay, so this is a pretty tailored and specific step process for um, problem solving, but it's something that can be really helpful for folks because it is so structured. So I hope that the information that I covered today was helpful. I know I kind of went through a variety of topics, but I really wanted to give folks an idea of what trauma informed care can actually look like in your setting and things that you can do and start implementing in your work to support your organization's overall implementation, hopefully, of trauma informed care in your organization. So before we wrap up, I do just want to put the QR code for the evaluation survey on the screen. You can just take a picture of this. Additionally, I'm going to put the PDF of the PowerPoint back in the chat. And once you download this, you can just click on this link right here and it'll lead you to the survey. Okay. Um, Really quick, I'm gonna go back to the other slide, but I do just want to say thank you. We appreciate your time, attention, and participation. Today's webinar was hosted by DBHR through the Washington Healthcare Authority. We would like to remind you that the slides and a link to the recording will not be sent out, but you make sure that you are signing up for the FCS email list so that you can get a wealth of resources and information from FCS. I did put the PowerPoint in the chat. And I also just be mindful that the link to the FCS YouTube channel is at the beginning of the presentation and you'll be able to view the recording there. And again, don't forget to check out the Foundational Community Supports newsletter for all things FCS and upcoming training events. I'm hopeful that you guys found this information helpful. Thank you so much. Let me just stop the recording.